Oh, you're on mute, mate.
We're good to go. I have the start webinar function here. So when we're ready.
Oh, no. That's good. I think Ange is probably going to come back in again in a sec. She literally jumped off. And then hopefully she'll jump back in again. That's weird, isn't it?
Yeah.
Adults and sporty kids, active kids, etc. Now, Ange is someone in very high demand in the world at the moment and has gone a bit of a campaign to try and increase the education, the awareness about how to manage and recognize some of these presentations that maybe we might not be as familiar with if we haven't been working with pediatric kids, etc. So a little bit of an intro for Ange is that she spent 35 years basically mastering her craft, trying to look for these answers to try and sort of educate both the athletes and now generously sort of helping to educate other therapists around how to manage some of these conditions and help to identify them, really. She does have a special interest in lower back presentations, so pars, defects, etc. She works as a physio to the Cheshire Cricket Board, and luckily, I'm sure Ange will tell you a little bit more about this, but she's actually coming to the Toon to deliver a one-day course down in North Shields on the 25th of March. So there's only a few spaces left. She's got an exciting announcement for the most interactive person, the person who tags her the most this evening. There'll be a place that potentially becomes available when Ange says. But just before we pass over to Ange, I just want to give a little bit of an update on where NEMS are with things just on current bits and pieces that are going on, really. So the first thing is the exciting stuff is our next event is going to be face-to-face again. This is a nice little interim one in January when everyone's skint and can't travel anywhere. But it gives, the next talk is all going to be on FCP in imaging. And we're going to have Andrew Cuff come and talk to us. The date is to be confirmed, but it'll be that week commencing the 21st of March. Another date for your diary is the 23rd of September, which is when the conference is next on. So this year's conference in September, 23rd of September, put that date in your diary, save it. We've already confirmed some amazing speakers. Little spoiler alerts will probably come in due course, but there are Liz Bailey and Mike James are going to venture up to the Northeast, amongst some other absolute worldies from a speaking perspective. The other thing which you may hear about, NEMS are sort of almost tapping into we want to hear what students have got to say in regard to some of their needs CPD wise and what you'd like to learn about to help prepare for the world of work. So your lecturers at local universities have all received information about getting someone to come on board and join us and the committee at NEMS. So it'd be great to have a student voice in that world as well. But hopefully we will send you all of those links. If you're interested, it'd be great to have you on board. But I'm going to pass over to Ange. This is why you're here tonight, to hear this. Thank you so much, Ange, for giving up your evening.
My pleasure.
I'm really looking forward to seeing it. There's over 100 people now tuned in to hear you. So over to you, and thank you.
Super. Thank you very much for that introduction, and thank you for giving me the opportunity to chat to you tonight. I'm just going to get my slideshow up and running from the beginning there. So hopefully now you can all see my slide. So I'm just going to pop that into present for you. Okay, so one of the things that I want for you to leave after tonight's introduction to MSK Paeds is why I truly believe that active kids are not just mini athletes. And so we just basically need to understand those fundamental differences. To give you an idea of who I am, as we say at the moment, I am absolutely on a mission to raise the profile of standards of care for junior athletes and try and get them access to the same high quality of physio that we offer to our adult patients. I'm on Instagram and I'm on Twitter. Given my vintage, I'm definitely better on Twitter than I am on Instagram, and that's at Angie J Physio. I was that typical young injured athlete. I played every sport going, but I never really understood why did I get injured and yet other kids who were on all the same teams with me didn't. And so I've kind of made it a bit of a mission to understand what my journey was like and what sort of things were going on with me that perhaps rendered me more susceptible to injuries than perhaps some of the people that I played with. That sparked a career that, as Steve rightly said, is now over 35 years long, but I've loved it, absolutely loved that whole career span. During the course of my working life, I've also become a mum to 2 international athletes, and they were seriously willing guinea pigs. Basically, they wanted to be the best that they could be in sport, and consequently were quite up for doing almost anything that mum threw at them in pursuit of that little bit of an advantage. And not all of it worked. They've still got 4 limbs, each of them, and mostly are in one piece for the majority of the time. But that gave me a real insight, because now I've been there as an athlete, I've been there as a physio, but I've also importantly been there as the mum to 2 high performance athletes. And that's enabled me to give advice to other therapists to say, look, this stuff actually works in practice, because quite often we have these idealistic views that aren't always easy to implement into family life. And I now spend the majority of my time, I'm still a clinician, but I spend the majority of my time now spreading the word far and wide about ways in which I think we can improve the quality of care that we give these young kiddies. So over the course of tonight, I'm going to try and convince you to join me on that mission and raise awareness amongst our professions. And what I want you to do is kind of make other people get excited about this. So as we said, I'm coming up on the 25th of March to give a course at North Shields. And so for the person who basically does the most little screenshots and tags and gets NEMS and myself a higher profile on Twitter, the one who is most socially interactive tonight will get a free place. So we're going to try and get people really involved in this mission. So what I want to do is see if we can look at making sure that you understand the differences between adults and children and how that impacts the pathologies. How do we understand the maturation phases of these young athletes, and how does that impact what conditions they might be susceptible to? And maybe understand the difference between growing pains and some of the other pathologies that we see. So if we just spend a minute thinking about, well, how are kids different? They have a different respiratory rate. The head is like a bobblehead. It basically is way larger for a good period of their childhood in proportion to the rest of their body. And think about when they go through a growth spurt, suddenly they look like they're all legs and these tiny little trunks. Well, those aren't the same sort of moving features that we see in an adult. The adult's world is pretty stationary, as opposed to a child can change week on week across all the different systems. And it may well be that they've grown skeletally, but that doesn't mean that they've grown up according to maybe their cognitive skills or their language skills. So all the different systems mature at different rates. So we just need to start to really understand where this child that is in front of us is at in order to make our pathologies. And so one of the things that's clearly not present in the adult is growth tissue. It represents the site of greatest weakness. The fisces, or the growth plate, basically is susceptible to damage. That gives us a whole different spectrum of pathologies. But the problem is, if you damage that growth plate, then you could be in for limb length changes, for angulations that last a lifetime. So we don't want to be missing these. So how do we set about making a diagnosis in a child? Well, we need to understand the anatomy of the immature skeleton. And when those secondary ossification centers that are related to growth, when do they open and when do they fuse? And how do we tell how mature this athlete is? And what factors are associated with the types of injuries that we see? So if we just take some examples over the course of tonight, what we're going to look at is seeing if we can identify maybe the top 10 things that I think are different and that things that we really don't want to miss. So children are different. If we just look at this picture of a wrist, then what you'll see is that it looks as though the radius is in two pieces and the ulna much the same. And if we think of that rather like a golf ball sitting on a tea peg, then we can understand how fragile that situation might be. The golf ball, or the bit on the top, is called the epiphysis. And then the bit that separates them is the growth plate, or the physis. And then we have the diaphysis, which equates in my analogy to the golf tee peg. So the diaphysis is the shaft. Just sitting above that is the metaphysis. And that's where all the vascularity of the bone exists. And then, as I say, sitting on top of that, we've got the growth plate and then the epiphysis. And each one of these bits comes with different pathologies. If we take the knee, for example, then at the distal femur, we've got the femoral physis and the femoral epiphysis. And these are examples then of what we call pressure epiphyses, the articulating surfaces, the weight-bearing surfaces. So you'll have a distal femoral epiphysis, or an EPIP, articulating with the proximal tibial epiphysis, and they will perform this pressure epiphyses. Now, different to that is, say, the tibial tubercle. And what you'll notice if you look carefully at this X-ray is that you can't see it. There's an arrow pointing to where it should be. But in this particular child, that tibial tubercle, what we call apophysis, the sticky out bit, hasn't yet become ossified. And so because it's cartilaginous, it doesn't show on this X-ray. So you can see where the arrow's pointing to it. Now, the distal femoral physis and the epiphysis is basically where we're going to see longitudinal growth. But at what we call this traction apophysis, or an APOP for short, is where the ligaments and the muscles attach. So if you think about where the quads tendon comes round and inserts onto that tibial tuberosity, that's at the apophysis. And we call this, therefore, a traction apophysis of different types. And there's no longitudinal growth occurs at the apophysis, but you do get a change in shape. So this is how the bone starts to take on its adult shape. And so we need to understand, well, when do they appear and when do they fuse? And so there's lots of diagrams on the internet that will help you. There's some of the, depending on the study and the population group that this was studied in, you'll get different sort of slightly different timeframes, but roughly you'll see that there's a theme that comes through. So if we just take, for example, that ischial tuberosity where the hamstring attaches to the ischium, think about what pathology you might diagnose in an adult. So if I said to you there's pain at the tendon insertion where the hamstring attaches to the ischium, in an adult, we'd probably be thinking about maybe a tendinopathy. But in a child, what you'll see there is that the actual ischial apophysis, or the point at which the tendon attaches to the bone, doesn't fully fuse until maybe the age of 25. So if you've diagnosed a high hamstring tendinopathy in a young athlete that's maybe 20, 21, 22, you've possibly got that diagnosis wrong. Look at the anterior superior iliac spine, 21 to 25 again when it fuses. So you can start to see that basically these are pediatric pathologies where this skeleton isn't yet fully ossified. And what you'll go on to see as the presentation goes on is that you're not going to be diagnosing tendinopathies in these. It's the physis that's the weakest link. So basically, these are going to be bony pathologies and not tendon pathologies in all of these areas: fifth metatarsal, the calcaneum, the tibial tuberosity. So anywhere that a muscle attaches in a child, in order to make a diagnosis, you have to know at what age they fuse. Once they fuse, then we move into adult pathologies. But prior to that, there's this window from appearance of the secondary ossification to closure, at which different pathologies exist. So let's think about, how do we work on a principle of working out how old this child is? If we know that these secondary ossification centers occur at a specific window, can we just use their date of birth? So have a look at this picture where we've got a boy in a white shirt who's clearly much taller. And then we've got a little chap there who's in a blue shirt. Now, who is the oldest? Well, in truth, we have absolutely no idea. We don't know whether the little boy in blue is older, but very, very skeletally immature. And we don't know what his predicted adult height is going to be. So the little boy in blue might be a really late developer that's going to end up 6'6". And the boy in the white shirt may have been a really early to grow, and basically he's all fully matured and that's his full adult height. So the little chap may fly past the other boy as they go through different stages of puberty. So height doesn't help us, and date of birth doesn't help us, and you'll see why in a second. And we've got to keep in mind that just because they're big and tall, which my son was at the age of 12, but he was so immature socially that quite often we'll expect great things of bigger kids. But is that always fair? Just because they've got a big body doesn't mean that they're necessarily going to be mature in other ways. So let's just look at these two x-rays. And this was a study that was done out at Aspetar with Mandy Johnson. If you look at the x-ray on the right, you'll see that my golf ball and tea peg analogy, or ice cream sitting on the corner, has already fused. They're already as one. And you can see that the carpal bones are basically fully mature. They're all there. We can see them. The metacarpals look as though they're pretty fused. And then look at the little lad on the left. It looks like half his carpal bones are missing because they've not yet ossified. That the radius and the ulnar are really skeletally immature, as are the metacarpals. So we can see that the one on the left is biologically a really long way behind the guy on the right. And yet what may surprise you is that their birth dates, so their chronological age, are within a week of each other. And yet the boy on the left has got a skeletal age of 6.3 versus the player on the right is 12.1, which means that in an under 9 age group, these boys have a 6-year age span. So a 6-year-old is having to play against a 12-year-old every week in the under 9s. So across football now and some of the other sports, we're getting what we call biobanding brought in, where you can actually get children of the same skeletal age, and we call that biological age, training with the same kids of the same biological age. So you may have somebody who's an under 12 athlete by their birth date, but they may be training with the under 9s. And you may have an under 9 chronologically who's training with the under 12s, just so that they all get an opportunity to either dominate in their biological ages, or maybe they get a chance to be challenged, because we don't want to make it too easy or too hard for these kids. Or think about the actual intensity that this little 6-year-old is going to have to work at. You think how much fuel the little 6-year-old's going to have to burn through in order to just keep up with that 12-year-old. So we just need to think about how hard that poor little boy is going to be working each session that he does, and what impact that may have on his skeletal system. So there may be up to a 28 centimeter difference in height, and we may see even up to an 8.6 kilogram difference in fat-free mass. So whilst this is a massively complicated slide, what I want you to understand is that what it's showing, and I would certainly recommend you to go and read this paper by Towson et al. From 2021, and it shows you all of the different maturation stuffs that you need to consider. If you take somebody at, say, Manchester City, like Kevin De Bruyne, then one of the best footballers in the world, without a shadow of a doubt. but he was a late maturation athlete. And that meant that potentially he was 2 or 3 years later than average going through what we call this peak growth spurt or peak height or peak mass velocity. So when a child is growing like a weed, in boys generally around the age of 13, girls usually 2 years younger, some of them will do this anything up to 3 years early. So there'll be what we call that early maturation, that green line that you can see the hill of. And then we might have our late maturation, like your Harry Kane and your Kevin De Bruyne, who will have really struggled in the academy system. You've got people like Haaland, great footballer again, let go by academies, wasn't selected because he just wasn't ready or matching his peers at equivalent chronological ages. So this should happen less and less. We should be making sure that these guys who are late maturation get an opportunity to thrive. But we need to understand this, because if we're saying that the secondary ossification centers have a window, we need to be able to identify these kids who are late maturation in order to understand when they might hit that window for diagnosing certain pathologies. So how can we do that without x-rays? Well, in essence, what happens is that different parts of the body grow at different times. So as you can see in this picture, the feet grow first, then the knee, and then the pelvis. And that's exactly, so if we think feet first, then the tibias, then the femurs, and then up into the trunk. And pathology follows it. So if we imagine that a child of around the age of 10 or 11 might well get pathology around that Achilles tendon into the calcaneal apophysis, and that we might call severs. A couple of years later, they may then get pain at the attachment of the quads to the tibial tuberosity, for example, Osgood-Schlatters. And then 2 years later, they may well start to get pain around the pelvis, and we call those pelvic Apophysitis, or sometimes we'll go on to understand that they're avulsions. So just looking at the kid and looking as to whether their legs are disproportionately long, are their feet huge, asking them if they've gone through a recent really big growth spurt, that can help us to start to assess where this child is at. But those kids who are prepubescent are very narrow hipped in the boys, or narrow hips, sorry, in the girls, narrow shoulders in the boys. And they tend to have chubby little faces and be quite rounded in their faces. So even just looking at the child, you can see which ones are the little people and those that are much more skeletally mature. And what you'll start to see is, if now that we know our anatomy and we know roughly how to look at maturation, and we look at the windows of ossification for the skeleton, we're far further on with being able to make some diagnoses. So at those articular epiphyses, the epips, we get conditions that are called things like Perthes. We can get the same condition called Kohler's at the navicular, Freiberg's at the second metatarsal head, Panner's in the capitellum of the humerus, and then we can get osteochondritis dissecans both in the knee and the elbow. But for our argument's sake, at anywhere where there is an articular epiphysis, we can get an avascular necrosis or an osteochondrosis occurring at any one of those areas. So be very careful what you're diagnosing in these adolescents. We will then also get conditions that are non-articular, and these occur at the apophysis or apops, Osgood-Schlatters, severs, Sinding-Larsen's at the proximal end of the quads tendon as it attaches onto the tip of the patella, and Isserlin's at the fifth metatarsal. So what we're starting to see, therefore, is that we can get these what we call osteochondroses occurring at every single muscle attachment onto a bone, and that one we'd call an apop, and at every articular surface, an epip. And the pathologies are slightly different, yet similar. So what happens in the epips, in the epiphysis, is that we get this inflammation that begins to occur the cartilage may swell, deform, and fragment. And what we get is a avascular necrosis, or a loss of blood supply to that subchondral bone, and everything starts to break down, which you'll go on to see in a slide that we have here of Perthes. So in the child's x-ray here, you can see one side looks as though it's all broken down, it's very flattened, and they've lost that shape of the femoral head. And this is a classic Perthes type presentation. And we don't really know why they occur in some kids and not in others. And that's going to be said a lot during the course of tonight. But what we do know is that with the right management, then we can make sure that these kids, for whatever reason, again, go on to ultimately re-ossify and get a relatively normal shaped femoral head again. So we get this breakdown period and then re-ossification. So the important part then is making sure that we recognize them. And these Perthes type children occur usually around the ages of 4, 5, 6. You may get one that is slightly later, and you may get them that are bilateral. And what you're looking for here really is a kiddie of this age who comes in and they're limping, not always painful, but they're limping. And the critical part in an adolescent or pediatric hip is that they may not come in with hip pain, they may come in with knee pain. And this is, I'm going to say that again in another example shortly. But what's important here is don't be expecting that the hip pathologies have hip pain. They will in an adult, but in a kid, for whatever reason, they will basically present with thigh pain and knee pain in at least a third of the cases. So this little chappie, usually a boy, is going to present with a decrease in usually abduction and internal rotation, maybe that painless limp. And it could be that these were the kiddies who maybe had a hip synovitis when they were little, and they then have gone on to get a Perthes, but not all of them. But certainly I would say that they quite often occur in these bouncy little children. Once we know that the pathology of Perthes and how we see that subchondral breakdown and then an eventual reossification, we can imagine that then that can happen, as I say, at any articular site. So if you've got a dancer that's suddenly got pain in the second metatarsal, it's not likely to be a stress fracture in a little person. It's much more likely to be Freiberg's. And as you can see, the pathology is different. Imagine trying to weight bear and stay in point on some of those positions. Again, in the older child, we may see a navicular stress fracture. In the younger one, we're more likely to see colas. So just be aware of these. Now, how we differentiate between what's going on in this hip is in a child, we need to know, have they got a temperature and potentially a history of a virus? So my son definitely used to go through 2 or 3 days where suddenly he would have probably bounced around. His nickname was Tigger. He was never still. And in essence, what we would probably see is that for a few days, he'd obviously exceeded the capacity of his body. And so he'd had no temperature. And when we had him scanned the one time, he had this little transient synovitis. And then it seemed to settle, and he had no further repercussions. And as I say, went on to be an England hockey player. So it doesn't always cause a problem. But in the cases where maybe it's associated with a temperature, they have a risk of osteomyelitis and septic arthritis, which can radically cause a breakdown in their articulating surfaces, and these need an urgent referral. So a child with limited hip rotation, painless limp or painful limp, and definitely with a temperature is a straight onward referral to a medical practitioner. So just bearing in mind that a lot of internal rotation, inflection and or abduction needs scanning. Let's think about another case. So this time an older child, may or may not be obese. The obesity isn't relevant anymore. It used to be on the way in which we used to think about this condition. But a young male with a 3-week history of left lower thigh and knee pain. No trauma, no red flags, nothing to write home about here, but he'd had to stop playing in his high school basketball team because basically he was limping and he had this sore left lower thigh and knee pain. And on examination, fully normal knee exam, nothing else, but he did have limited internal rotation in 90 degrees of flexion. Okay, so we're thinking now, not dissimilar, we've got that limited internal rotation. The presentation of pain is more distal. And this one is an older child who will have a slipped, what we call capital or upper femoral epiphysis. Think of it like the golf ball slipped off the tee peg or the ice cream has slipped off the corner. If this kid walks in, then the probability is that they've got a relatively stable slip. But if they're limping like crazy and they can barely weight bear, then you have to assume that this is now unstable, and this is a straight to A&E. Because imagine the vascularity of that poor little hip if that slips more than 50%. So these guys have got a massive risk of avascular necrosis and long-term future of potentially a hip replacement. And certainly during COVID, when kids weren't going to A&E, they weren't coming into physio, we've got some absolute horror stories of both stress fractures in adolescent hips and SUFIs that basically didn't get the right management and have now got long-term hip disorders. So again, we're talking loss of internal rotation, in this instance, in flexion. The leg will often be in marked external rotation, usually asymmetrical, so they can be bilateral, but you'd be damn unlucky if you slip both at the same time. So again, onward referral. So knee pain in children is the hip until proven otherwise. So this is going to be a whistle-stop tour. It's just a real get you thinking about the different presentations. So let's think about our APOPs now. What happens at the insertions of the tendons onto the bone? Very cartilaginous bone, remember that. And so if we get these repetitive forces that exceed the capacity of the tissues, nothing different to the same pathology as with a tendinopathy. You've done too much too soon. Same as a stress fracture, but in this instance, it's microtrauma where the growth plate is at the apophysis. So what we need to remember here is that in an adult, the tendon is stronger than the bone. Sorry, rethink. In an adult, the bone is fully fused and therefore is stronger than the tendon. Rewind. In a child, that growth plate is still very immature. So relatively speaking, the tendon is going to be stronger than the bone. So in a child here, with certainly an open growth plate, what we're basically talking about is an injury to that growth tissue, not the tendon. That's not to say that there isn't any inflammation in the tendon. We went through a phase of saying it's never a tendinopathy in the child, but there has been shown to be some neovascularization into not only the tendon, but the bursa. But the primary drivers here are bone marrow edema and inflammation at the site of the apophysis. And that little apophysis, if you imagine it as being not yet attached to its parent bone, it can, with traction forces and growth, you can imagine that that distance may widen. And we may start to see little ossicles forming, fragmentation, and certainly some tendon thickening. The problem we've got at the moment is if you look at the research on Severs and Osgood-Schlatters being more papers than any other part, is that when you actually review a normal skeleton, we see that there's a period of transient deficit in bone mineralization. Makes sense, the bone's getting longer and it takes a while for the actual density to catch up. And we can see in the normal asymptomatic kid, fragmentation, ossicles, sclerosis, and a widening of the apophysis. So how do we tell which ones are a pathology and which ones aren't? So let's just think about this little chappie. He's 11 years old and he's woken up with heel pain. It's been gradually getting worse over the last few days, and it hurts when he plays sport, but it's okay when he rests. So he keeps going through this boom and bust culture where he keeps going back to sport, and it hurts, and then he settles it down for a few days, and then he goes back, and he's come to us now because it's getting worse and worse and worse. And he's really tender where that Achilles tendon inserts onto the calcaneum, and it can be around both the medial and lateral sides as well. He's got a normal ankle range. So what we're looking at here is what we call, posh name, calcaneal apophysitis or apophysitis. Can have different names, or maybe we should just stick to calling it severs. But try and omit that word severs disease. I'm not a massive fan of telling kids they've got diseases when in essence what we've got is a too much too soon situation in a normal ossification site. So what we want to think about here is that we can't diagnose an Achilles tendinopathy in this kid until that calcaneal apophysis has fused. And look, it could be anything up to the age of 17, plus or minus a bit for a late developer. It's more in boys. And what you'll see in the research is that in severs, only 1% of them occur after peak height velocity. So whilst it may take a while for this apophysis to fully fuse, kids that have done their growth spurt and present with heel pain is not severs. Kids who are pre-growth spurt or in the middle of a growth spurt with this heel pain, quite probably severs. So it helps us to understand that maturation phase. When we start doing ultrasounds of these or scans, we're going to see that very similar presentation. But what we usually see here is more bone marrow edema and certainly lots of soft tissue edema. And as I say, it can infiltrate the tendon, it can infiltrate the bursa, and that's exactly the same as we see up in the knee with Osgood's. So once we understand one of these apophysitis injuries, we can understand the rest of them. So let's compare that now to, well, what are we going to do with this 15-year-old? He's got exactly the same symptoms. Have a think about for a minute, what might this be then? So this kiddie's post-peak height velocities is calcaneal apophysis might still be open, but we said only 1% of severs occurs post-growth spurt. I'm going to tell you this kid was an early maturation athlete, fully matured, and basically post-peak height velocity or his big growth spurt. So what do you think the most probable diagnosis for this kiddie could be? So what we need to be aware of is it could be a lot of things. Just because they've got heel pain and just because they're a kid doesn't make them all severs. We have to understand that these kids can get stress fractures. I had a boy who completely fooled me last year, who presented like a severs and was pre-growth spurt. And yet what we didn't realize was he had a genetic family history of failure to absorb vitamin D. And so he had bilateral calcaneal stress fractures. So he was suited and booted for 3 months in the end because we just couldn't get him to heal until we'd got the vitamin D levels up to a decent level. But you can get all sorts of other conditions, including nasties, including infections and inflammatory bone diseases. So we need to have our wits about us when we're doing our special questions to make sure that we don't miss any of these pathologies. If we think in terms of the knee, we just need to think about how do these occur? And it's helpful to think about not only the fact that if you've got growing tissues and growing bones, then the poor soft tissues are playing catch up. And yes, there'll be a massive traction on that insertional site. And that may be the case where you've got the attachment of the Achilles for that severs, and it may be the case with regard to our traditional thinking of Osgood's. But more recently, the research is also showing that if you've got this neovascularization into both the patella tendon and the bursa, then if you compress that tendon, it's also going to be sore. Now, compression, no doubt, will be caused by kneeling, but where does that leave us with quad stretching? Because that's going to increase those compressive forces and therefore potentially changes our management. But all of these boil back to exactly the same as an awful lot of our adult pathologies when we're talking about osteoarthritis, when we're talking about tendinopathies and bone stress injuries, that the load has exceeded the capacity of the athlete. So this means we've got to get really good at looking at our subjective and understanding what they're doing, both physical and mental, and how they're balancing that with recovery, sleep, nutrition, and stress management. And we'll talk about that a little bit more in a second. But I want to shock you, because I hope it will, in that when I read this paper by Sinead Holden, and I'd like you all to make an effort to read it, that basically the mean duration of pain in Osgood Schlatters is 42 months. That's a really long time. And do we tell kids when they come in with what we might call a traditional growing pain, do we tell them that they're in this for at least 2 years and maybe 4? And that most of them will have ongoing symptoms that affect their sports performance during that time. And that 1 in 5 will probably stop playing sport during that time with this condition. So we've got to be honest with this population group, because you can't tell a kid they're going to be better in a few weeks, because they're not going to come back to see you when that pain just keeps going and keeps going. Now, my belief is that if we got the management of these kids right from the start, they wouldn't have it for 4 years. And I believe we can change that. If we get good at this and understand the pathology and start to treat them as we would like the adults, think about what your return to sport protocol is for an ACL. It's going to take you around 9 months to get that kid right back to sport. It's very much based on criterion-based, really good testing, progressing them into hopping, into multidirectional, maybe looking at some of the neurocognitive work, and compare that to the last kid you saw with either Severs or Osgoods in your clinic. How good was your rehab then in terms of, did we really truly prepare them to go back to sport? And yet the return to sport that they're going to do is the same. So we need to really start to wise up to, is it good enough what we're giving these kids? One of the things we know is if they've got an associated bursitis, and so you can poke and prod them and find out, then one of the things you'll realize is those are the kids that last longer. They had a poorer outcome measure score when all of the questions were asked at the beginning. So we can start to get to recognize which kids might be in danger of these chronic conditions that we've got to get better at diagnosing and treating. And one of the things that I'm often asked is, how do we tell whether it's growing pains or an overuse injury? So how do we tell whether it's like an apophysitis or growing pains? Well, often I would say that you want to think of growing pains as being generally bilateral. My belief is that they're probably to do with the bones are growing and that neural tissues maybe not yet managed to catch up. So we know that they're not going to be tender. The pain will be intermittent. And yes, growing pains occur at night. So now we've got to start going, well, how the heck do I know that it's not a tumor? Well, you'd be pretty unlucky if you got a tumor in both tibia at the same time. So because they're bilateral, they come and they go. They don't generally get worse over time. And I think that these kids tend to be the little stress heads. They tend to be maybe the ones that have got a slightly more anxious personality. Are they very tired? Do they have poor sleep anyway? And these are the ones that you want to start looking at. And maybe they have lower bone density. And is that linked to vitamin D deficiency? Or is it just the bone's done a big growth spurt and we're waiting for that bone density to fill back in again? But is that also linked to vitamin D deficiency? And then compare that with an overuse type injury, which is generally, it could be unilateral, could be bilateral, but they're not going to cause night pain. Very few of these apophyseal type injuries will ever cause night pain. And it's going to be aggravated by activity, whereas growing pains tend to be worse when they're in bed at night. So you can start to see how different they are and how easy it is in your subjective questioning is good enough to differentiate. So I did promise a whistle stop tour. So where are we now? So up in that pelvis, and have a little think about what you think this particular diagnosis may be. And think about what I said earlier about what's weaker, the bone or the tendon in these kids. And think about the age of ossification of this area of the pelvis. What do we know about it? You can see that the femur's fused, so the kid is relatively mature. So let's just think about what that might be. And what we're looking at here is that around the pelvis, at any place that a tendon attaches, you can get an apophysitis, which is like a sort of gradual onset, just like Osgood's and severs. But the drama at the pelvis is because these muscles, now we said, severs in the 10 to 11s, Osgood's in the 12 to 14s, and then 14s to 16s, we're starting to look more at the pelvis. Think of that huge burst in testosterone in the boys, in sporty little footballers, the size of the muscles, they're getting stronger, and that pull on that immature bone could cause an avulsion. So around the heel, around the knee, very, very rare to see them avulse. But around the pelvis, it's seriously common. And if we miss this and we treat them like a tendinopathy and we send them back to sport too early, and worse still, we get them doing a ton of deadlifts and stretches and all sorts of things, then they're going to widen that apophysis even further, and these are going to become problematic. So let's just remind ourselves at what stage those secondary ossification centers appear and close. Anterior, inferior iliac spine, all closed in this study by 17, but the ischial tuberosity, 23.8. Now shock yourself, look at the symphysis pubis, 30. So some of them may be closed by 20, but some of the cohort hadn't closed till the age of 30. So at what stage can we start applying adult pathologies? This happens in the shoulder. The clavicle doesn't fuse, the medial clavicle doesn't fuse until late 20s. So you can't diagnose in the lateral clavicle and ossicraniale until well past the age of 25, because these growth plates haven't yet fused. So this analogy works well for me. But certainly at the pelvis, we need to think about the fact that these kids, when they present with pain at the insertion of a tendon, are at risk of an avulsion. We need to downpower them and take them out of all high intensity sport. That climber could fall off that wall for two reasons. In the adult, the rope is going to fray. In the child, the anchor is going to pull out of the wall. So think of it as being the attachment in the kid and the tendon in the adult, and he won't go far wrong. So these pelvic avulsions are a forceful contraction. If we think about the rectus fem, it's going to be on kicking and sprinting. And what you may or may not get is a popping sensation. The last little boy, he'd not had a scan done at this point, but he walked in and he said, I felt like the front of my hip fell off. He absolutely knew he'd had a bone stress injury and that basically this avulsion was quite big. He felt sick. And he'd heard the popping sensation, and in his head, he knew he'd done something. And he is one that's over 20 mils separation, and he's going for surgery. So children rarely present with the driving force of being a tendinopathy, and be aware that in the pelvis, these can avulse. Let's move it through to the physis now. We've done where the tendon attaches. We've done the articular surface. Now let's think of the physis. Okay, this is the structure where we get longitudinal growth. So what I want you to think about is the physis is the weakest link. An ankle sprain, lateral ligament sprain in an adult will probably traumatize the ligament. In a child, it will probably cause a physeal growth plate injury. And we call those Salter-Harris fractures. So you've got to keep this massively high suspicion index. If you diagnose a lateral ligament sprain in an ankle of a child pre-puberty, you're probably wrong. They can damage the ligament, but imagine the forces that have gone through that very immature physis. And what about what's going to happen if we miss it? So we have this thing called a Salter-Harris classification. The SALTER is where the fracture occurs. So in a type 1, it's straight across. In an A above, type 2, you can start to see. But when we get up into 3, 4s, and 5s, you can see that it seriously could affect the potential of the longitudinal growth in this bone. If you bisect that growth plate and you miss it, then in the type 3 and type 4, there is a potential for angulation. So one half of the bone continues to grow, but the other half doesn't. In your type 5, which occur in the radius, in what we call the gymnast wrist, then basically the growth plate has been crushed and that limb will not continue to grow. So the radius stops growing, but the ulnus goes flying past it and causes all sorts of impact injuries. So we need to basically think that in what you might be thinking of a ligamentous sprain, I had a gymnast in who basically kept telling me that they'd sprained their wrist. Well, they hadn't actually injured it, and therefore it was going to be one of these impacts to that radius. But what we need to remember is that the growth plate is the weakest link. So in a child, you need to get these x-rayed. I know with the Ottawa rules and everything, in an adult, we'd be quite cautious about x-raying, but if we miss this growth plate injury in a kid, then the long-term implications for limb length are quite catastrophic. So we need to get really wised up to these. So let's move up to the knee or the elbow. If we were to say the knee is locking, giving way, and it's swelling, think about your adult diagnosis. Now think about in the knee, it's not going to be a meniscus. Could be, you can get a lateral meniscus in the knee, but it's rare and they're under 10s. So let's say we've got a 14-year-old boy come in, the knee is locking, giving way, and swelling. Okay, what we're looking at here is, do they have a temperature? No. Well, if they've got swelling and no temperature, then we can start to go down our differential diagnosis. If they have got a temperature, just like we talked about, then we need to get these guys scanned and immediately to A&E. If they've got locking, however, it limits us down to just a few conditions. So if there's true locking, yes, it can be a discoid lateral meniscus in the under 10s. But the most likely diagnosis is what we call osteochondritis dissecans. And in this condition, that superficial cartilage, the articular cartilage, fragments and breaks down. And again, you can imagine if they start getting those type 3s, those type 4s, where the fragment is unstable, then think of the catastrophic effects of leaving an articular surface like that during adolescence whilst they go back to sport, and the impact of early OA changes. So these kids take about 6 months to rehab. Some of them need surgery if the fragments become unstable, and some of them can be rehabbed quite effectively, conservatively. But they don't all have trauma. Some do, some don't. So start to get your wits about you. If you've got this history of locking in the knee, then again, we're going to need this to be imaged. So we've not talked about low back pain in these young athletes, and particularly a young male athlete in a window of, say, 10 to 23, 10 to 24. So what would your differential diagnosis be there? So a young athlete with a history of low back pain for greater than a week is a pars stress fracture until proven otherwise. And that seems pretty radical. But if you decide that you're treating them as a bone stress injury, even if it's just bony edema, but you power them down for a couple of weeks, then what you're going to do is stop this child from progressing down this sort of continuum. If we can pull kids out at the first sign of low back pain, it will be related to extension-based activity most commonly. In this sort of right arm bowler, so if we go back, left arm bowler, the bone stress injury will be on the contralateral side. You can see that through the side flexion. I'm just doing some research at the moment. We're setting it up to try and work out whether it's the stance leg or the kicking leg that most commonly gets a bone stress injury in a soccer player. Rugby, it's quite often bilateral. But the important part, and if you get nothing more than this, and you see a kiddie who's getting, and maybe your own children, who are getting intermittent episodes of low back pain, particularly related more to extension-based sports, then effectively you want to power them out of sport really quickly for about 2 weeks and let that body and bone create that adaptation that you need to get healing. If we do that, they'll only be out for a few weeks. But if we miss that window and they carry on playing with just a little bit of low back pain, settles with rest, then what we're looking at is an incomplete fracture. That's 4 months out. If we progress to a complete spondylolysis or stress fracture, that could be anything up to 6 months out, and they can progress to a slip called a spondylolisthesis. But the important part here is that we could have stopped this through education of the athlete, getting out there to every coach, every kid and every parent to let them know that basically, if they stop at the first sign of back pain, or if we really manage them well at the first sign of pelvic pain, then we could stop these from progressing to much more longer injury burdens and time out of sport. So while we're on that topic, just for a second, what I want you to think about is this case. And this was a case that I'm writing up at the moment, and for me is a really, really important part of my management of patients. So we've got a 12-year-old female with intermittent left posterolateral knee pain, no locking, no giving way, nothing really in the history. Typical sharp increase in volume in the last month. This kiddie went at life at 100 million miles an hour. Her intensity would have always been a 10 out of 10. She'd have said it was always 11 out of 10. She played tons of different sports, always playing up an age group, a really good little sporty kid. Had a recent growth spurt. She never had a rest day. And the 2 points that I want you to pick up on here are 12-year-old that hadn't started the periods, nothing odd about that. That's still within normal. If she was 15 and hadn't started a period, that would have been relevant. But the critical bit for me here, and do you ask this question, is, do you have breakfast? And the child said, no. I feel sick in the morning and I'm always late out of bed. But what do you have for lunch? I don't have lunch because I play sport at lunchtime, and generally I don't like the sandwiches that are left by the time I've finished playing sport. So this kid ate once a day. And what we know is that even in small children, if we haven't got enough energy going into the body is no different to our mobile phone. And what we know is if your phones now have had a long day and they've suddenly gone into power saving mode, I want you to think about what that means. Because when I describe this to kids, they usually say, my phone goes into slow down move, it shuts down some of the apps so I can't use them. And I'll say, well, that's precisely what your body does. So when we go into either stress through a psychological stressor, or because the body has experienced a period of low energy availability where it thinks that maybe there's no more food coming, and it recognizes that it hasn't got enough, and so therefore it prioritizes the energy it's got, and it starts shutting down the apps it doesn't need. So imagine that you were being chased by a lion and you were a little zebra. The only thing you need right now is your cardiovascular, your respiratory, your muscles, and to keep your wits about you. But you need to digest your breakfast, lick your wounds, sort out your immunity. And more importantly, do you need to spend some time reproducing? Well, no, you don't. You're being chased by a lion. So at this point, we're going to power down all those non-essential services. And the impact of that is it changes the activity in the hypothalamic pituitary axis. And the impact of that is that what it does is starts to cause alterations in our bone density, and we have an increased risk of stress fractures. This kiddie had a tibial stress fracture. Okay, they're rare, but we're starting to see more and more of them because kiddies are doing loads of sport, and a ton of them are either intentionally not eating through disordered eating. I have another slide that would have done exactly that, but the kiddie had decided to go carbohydrate free because her mother had. Kids can't do things like that. But more importantly, this one was unintentional. She just didn't know. And once I educated her, we turned around really, really fast. We're nearly there on our conditions. So think about this little 9-year-old high-level gymnast. She presented to me with right hip pain, and she had pain on hopping. The only thing in the history, the hip examination was completely normal. She wasn't limping. She was a bit weak through the glutes. But when I looked at her balance was awful, absolutely shocking on both legs. So she couldn't stand on her right leg or her left leg with her eyes closed. And so because of this history whereby she'd been telling me that she was vomiting on a daily basis, and although she'd seen a consultant at the hospital who diagnosed stomach migraine, coupled with a complete inability in a high-level gymnast to stand on one leg, the features just did not fit. And I sent this kiddie back to that same consultant and asked for a brain scan. And sadly, the kid died 3 weeks later of a brain tumor. And these don't happen often. But you can't tell me that we didn't think that the features were strange. This kid had no balance in a high-level gymnast. So we've just got to make sure that we keep really aware of our red flags, and we take the same detailed history that we would do in an adult. Because kiddies can get all of these weird and wonderful conditions, and it would take me an hour to go through my red flags presentation, because they get inflammatory arthropathies, they get different tumors, they get different bone conditions. So we do need to be aware of these other pathologies. But until you know all of those, stay aware to taking great subjectives. And if the features don't fit, then ask somebody more senior than you or a doctor to examine this kid. I would highly recommend these two resources. The Versus Arthritis MSK assessment is a great little booklet. It's a PDF. And the PMM online is a brilliant resource for looking at all of these red flag type areas. So my dream is to get really good rehab for kids with Osgoods, with avulsion injuries. It takes me about 16 weeks to get a kid back after a pars fracture or an avulsion injury to the pelvis. And these are going to really, be frustrating for kids. And we've got to get our management to be just as good as yours would be with an adult ACL. We've got to take a great history, and we've got to understand why this kid got injured. What training errors were they making? Was the kid having breakfast? What can we look at and become like my little girl that never stopped saying, why, mummy, why? The more inquisitive we are as therapists, the better therapists we become about understanding why, and therefore how to prevent this from coming back. We need to make sure that we understand each of these different areas. And again, it's beyond the capacity of tonight's talk to get right into how to do that subjective. But what we really need to do is get good at asking questions, maybe uncomfortable questions about, have they lost their motivation? Is there any psychological things going on? What do they have to eat? Have they got any eating disorders? What's their sleep pattern like? And really start to understand these non-sport stressors so that we can really get a grasp of what we call the intrinsic risk factors of an injury that decrease the capacity of the athlete versus our extrinsic, which are usually the training errors. So there's so many different things we need to get into. And it takes, what I generally do is most of these get done in my pre-assessment questionnaire that gets sent out before I see a child, so that gets me over the embarrassment of some poor kid being asked whether maybe they've started their periods yet in front of their dad. So a lot of this can be done in a really good bone stress injury or a pediatric questionnaire, subjective assessment that you can send out in advance of your session. Just a couple of little things that I want to highlight is you can't sort of expect the child who's never had an injury before to have the vocabulary that maybe somebody who's been there and got the t-shirt and they've had a nerve pain, they've had a joint pain, they've had a soft tissue pain. Kids won't have that. And we need to be very, very careful about the types of questions that we ask and use the vocabulary that they want to use. Whatever description they give you of that symptom, you're going to have to use those words if you're not going to A, confuse the child, or B, not get them on board. And we need to think about when we ask them for a VAS score, children under the age of 8 don't get it anyway, but over the age of 8, you might well use it. In the under 8s, we use this Wong-Baker. But if we talk about the children over the age of 8, which you're more likely to see in your adult MSK clinics, then what you just need to remember is the majority of kids will describe a pain as being something like an 8 out of 10. And what they really mean is, I'm so frustrated by it because I want to play football, but I can't play football. And the mum's looking at the kid as if to say, 8 out of 10. And you're looking at the kid who's just with severs jumped off the bed onto their sore heel. And so we've got to understand what it is that's making the child give it an 8 out of 10. Is it truly how much pain it is? Bear in mind, they've never had pain before, so they don't know what an 8 feels like. And so we can't just read those same adult techniques straight into the child. In exactly the same way as we do in the adult, we need to be good at outcome measures, but make sure they're pediatric versions. The kid's not going to sit through a 4-page document answering loads of questions they don't understand. We need to get good at capacity testing and strength testing. So these are some of the outcome measures that you might use in the adolescent population. So things like the International Knee Documentation Committee, the IKDC, has got a kids version. The knee osteoarthritis one has got a kids version. So you need to start to look and see which ones of them you can apply in your clinical practice. Kids love gadgets. If I use my jump app to see what their vertical jump is, then you can get the definite idea that they're going to be really competitive. They're going to buy into your rehab protocol because they want to beat their numbers next time. So I use my electric goniometer or the one on my phone. I use my handheld dynamometer. I use my jump app on my phone because kids love numbers. You want to get buy-in of your really boring quads exercises, then the more data you give them and the more challenges you give them, the more likely they are to buy in. But also it helps you with them buying into. I had a young lad with an avulsion of his adductor. He said, Angie, I'm ready to go back to sport. It doesn't hurt, honest, it's absolutely fine. We put the handheld dynamometer and there was a 50% difference between isometric adductor strength. The kid couldn't argue. And at which point he goes, well, yeah, maybe it does still hurt a bit. So having those data-driven conversations take the kids' lack of understanding of the responsibility and the idea that they might lie to get back on the field. This particular study by Johansson was superb for helping us to understand what kids want out of therapeutic interventions. And there's the usual stuff, include them in conversation, address their fears and beliefs. And you might go, yeah, I do that with my adults. But how do you describe, say, an avulsion injury of the ischial tuberosity? How would you describe that to a kid without freaking them out that the bone's pulled away from the pelvis? How would you tell a kid who's got Osgood-Schlatter's in a language that they can understand, but not only understand, they can repeat it back to their PE teacher and their mates in the playground? What kids want is a diagnosis that they can understand, a treatment approach that they can understand. So I get kids, so each of the children's diagnoses, I then have them in different descriptions depending on the maturation of the child. So my Severs description is a lot simpler than maybe my Osgood's because the kid will be younger. And we want to give them that self-confidence to know how to manage these conditions. They can go back with Severs and Osgood-Schlatter's with anything up to a 2 out of 10 pain. But if it went up above that, they need to rest. So how are we going to help them explain to their PE teacher why some days it's okay to do exercise and yet on others they can't? And this Me First program that Great Ormond Street have brought out with kids have got some really helpful resources about how to communicate well with children. You'll see that my back to sport tool is no different to what I would expect you to be doing with an adult. Look at it from an ACL perspective. We do sprinting, then change of direction, then we do our return to training before we do our return to performance. So no different. But do you take it to all of those levels? And do you really ask the questions that help you to understand the demands of what this child is going back to? Because we need to make sure that we absolutely know how many units of sport they're going to be doing, at what intensity, at what standard, and what's been going on if they've been out for 3 and 4 months to the rest of the squad. They've probably got stronger and improved. So we absolutely sure we know what this kid is going back to. And what we want to do is find them some level of activity that they can still do to keep fit. So if they've got Osgood's, which of these steps can they start at with no more than a 2 out of 10 that settles within an hour and is no worse the next day? And each couple of days, we can start to see if they're ready to progress a little bit further and a little bit further. But giving them this information helps them to self-manage the good days and the bad days. And just think in terms of, as I say, we've got to take them to exactly what we would do if you follow something like the Melbourne ACL Rehab Guide, which is a brilliant ACL protocol. To go back to performance, you've got to be at greater than 95% across a bunch of metrics. You'll have done multi-directional running, acceleration, deceleration, cutting, change of direction. And the more recent research really highlights that need to go from that controlled environment in your 13-foot squared treatment room to being able to meet the demands of the sport. And how often do we do this with adolescents? And is this why some of them can get pain for 2 and 4 years? What we need to do is make sure that we not only do our normal rehab, but also integrate the neurocognitive stuff. Kids love this. Virtual reality training when they're doing stuff, giving them, count backwards from 100 whilst you're doing that drop jump. Let's see if we can do your times tables, give them challenges, get them working in front of the PlayStation where there's a roller coaster moving. Maybe get some shades that you can actually make a bit more opaque so that they're really having to learn to dual task. This is the bit which is important, is making sure that the kid is ready for the multi-sensory demands that they're going back into. Kids are running around shouting and screaming, coaches are yelling, parents are yelling, and we've got to make sure that the kid can not just do a drop jump under control, but can do it when there's a zillion things going on. This is my final slide before we sum up. And what I want to just highlight here is that I wrote a paper for Physio First, so I don't think you can just Google it and find it, but I'm very happy for you to email me and ask for a copy. And it was understanding the youth athlete and factors associated with the risk of injury and illness. And in that paper, I look at all the evidence that supports all of the things that we want to talk to our athlete about. Because unless we cover all and each of these different factors, the kid will go back to sport, they'll perform the same training errors again. And before we know it, the kiddie who had severs has got Osgood's. And the kiddie with Osgood's goes on to get a hip avulsion or a lumbar stress fracture. So what's important here is that we really understand, not only with our kids, but with our athletes, what those training errors are, what their attitude and beliefs are about recovery. Are they getting enough food, sleep, protein, vitamin D? And are they strong enough through their growth spurts? What's their movement patterning like? So that we understand what the demand on this athlete is. So in summary, hip pain often presents as knee pain in children. Loss of hip internal rotation, inflection, or abduction should be investigated. A child with a joint pain and a temperature needs an investigation and an urgent onward referral. A sprain in a child is more likely a Salter-Harris fracture. Pain at a tendon insertion is more likely to be the apophysis than it is the tendon. And around the pelvis, it has a risk of an avulsion fracture. Extension-related low back pain in sporty kids is a stress fracture until proven otherwise. And locking, giving way and swelling is more likely an osteochondral defect, not a meniscus. Low-level vitamin D is a huge issue in children right now. We're at pandemic proportions in the north of England. You guys are further north than I am in Manchester. And just like the adults, kiddies do get nasties. And this tissue is highly metabolic. So just like our adults, we've got to get really good at the red flags. I hope I've inspired you to want to get out there and make sure kids get access to the right kind of treatment. You don't get this on undergraduate courses. So where are you supposed to get this information from? If you want to go and work in academies, private clinics, or adult MSK clinics, you are now going to see kids of these sorts of ages presenting with these sorts of conditions. So I offer loads for free. There's an MSK Peds Needs Facebook group, which I manage, and that's a great place to put case studies that you're stuck on. There's lots of serious gurus on there. As I said, I'm on Angie J Physio on Twitter and Instagram, and I regularly review the literature, do infographics and stuff like that. And every month I sum it up in a newsletter. So you're very welcome to sign up for that on my website. And I'm trying to basically raise the awareness of these sorts of conditions. If I have inspired you and I'm venturing north, then please do come and snap up those last few places on my in-person course, which is all about that return to play, taking kids through that assessment process and how do we work out when they're ready to return to sport. All of my courses can be done online. There's mini modules coming out. There's a new upper limb one coming out next week. And I'm looking for testers at the moment to just bulletproof it and make sure it's ready to go. So let's get on board and let's really improve the standard of care for kids. And I really hope you've enjoyed tonight. And I thank you very much indeed for joining me.
And on behalf of everybody and myself, that was sensational. Thank you so much for that. I think it was absolutely faultless. You can see you love it. I think everybody, numbers wise, I think it's the only talk I've ever seen where the numbers kept going up and up. I don't think there's a single person who left. As I've dropped into the chat group, guys, if anyone has any questions that you want to ask Ange, please just do pop it on there. She shared loads. But I'm sure there's a fair few little questions that are coming through. Are you okay, Anne? Some of those to you?
Yeah, I'm on the Q&A. I'll hit the Q&A first. People have split it between the chat function and the Q&A. So in the Q&A, anonymous attendee, is there a link between bone density and severs? Certainly you get a reduction in bone density in severs, but you get a reduction in bone density in any growing child. And therefore, in the non-weight bearing cerebral palsy kids, we have to assume that they are certainly at greater risk of a bone stress injury. And because often they're in more plantar position, then they're more likely to potentially get a tightness through that Achilles tendon complex. And as we see these kiddies getting more and more sporty and getting greater opportunities to play sport, then I would imagine we're going to see more severs in these kids. But because of the perhaps slightly different weight bearing. So severs is only going to be brought on by an increase in activity that the body wasn't ready for. So it's an exceeding the capacity of the bone. So unless they're fully weight bearing and starting to do as cerebral palsy kids are doing, getting into footy and all sorts, then they're not going to get severs unless they're weight bearing, but they could get bone stress injuries if they then suddenly started to do more weight bearing through a standing frame or starting to get on their feet more. So probably a little bit out of my comfort zone because I don't see CP kids, but certainly the logic would be severs is due to a sudden increase in activity most commonly. I'd certainly get all my cerebral palsy kids on vitamin D. So hopefully that would help. So Kirsty, what advice would you give to a 13-year-old female hockey player in the middle of a growth spurt complaining of bilateral tight hamstrings? In the absence of pain at the insertion, so up at the ischial tuberosity, if they've got tight hamstrings, then what I would do is no problem. I don't have a problem with doing some stretching as long as they don't have pain up at the pelvis. But they've got to do it in a really good position. So you want to make sure that that spine is really, really straight, as in they're not flexing and doing that ridiculous shoe the chickens where they're trying to go into a slump standing up with their head down and chest down. It's got to be a real chest up, lumbar spine dissociation, more like a deadlift. So I can show you pictures of that, Kirsty. I think there may be one, in fact, of a cricketer doing a hamstring dissociation followed by a single leg deadlift, both of which are brilliant for tight hammies, because what you're really wanting to do in my world is address why the hammies are tight. What are they trying to do? So I'd be there basically giving them a glute activation program, strengthen up the core, if you want to call it that. But for me, this is about doing some hamstring strength and some glute strength and trying to give the hamstrings a bit of a break. But some kids do get tight hamstrings. If it's bilateral, I'd also look at a slump. I'd be very, very mindful of the fact that if you've got a bone that's growing and the hammies are basically complaining, what do you think the nerves are doing? They're tiny. So what we want to do is address the neural side, address the fact that hamstrings are usually acting a little bit like the guy ropes on a tent, that it should have intrinsic stability from its ability to just like pop up like a tent does, and it should only need the guy ropes on a windy day. If the kid's battling with tight hamstrings, something is wrong with the intrinsic stability, and therefore look a bit deeper as to why. So Paul, would you advise vitamin D supplementation, especially in the winter months? And if yes, what IU dose? So Paul, I can only tell you, as I tell my patients, that I take 4,000 IU a day in the winter. And my kids were taking, as adolescents, 2,000 IU, but I'm a good physiotherapist that doesn't prescribe. But if my patient asked me what my kids took, then I might send them a picture of exactly what they did take and exactly the dose that my kids took. So be very careful with your prescription, and be very careful that you say, if you ask me what my family take, I can share with you that information. If you want to use that, that's great. We put all our bone stress kids under the age of 12 on 2,000, over the age of 12 on 4,000. And don't forget, you've got skeletal maturity to bear in mind. So the 12-year-old might be a 15-year-old, but they also might be still a 9-year-old. So just bear in mind that 6-year banding on maturity before you leap in and decide what's relevant. More of them onto vitamin D. No, I don't refer to a blood test because the EIS, as probably Steve will tell you better, but the EIS threshold is double what the GP's threshold is for what low vitamin D is. So if GP will diagnose you if you've got a blood test that shows 50, the EIS want you to have 100. So basically you need to be aware that practically every kid in the country, because we use sunscreen, so even if you did let your child out into the sun, the chances are you've got them in a rash vest if they're very little. My daughter is a professional windsurfer. She has sunblock on the whole time and a long sleeve rash vest on. Every single comp, they give them a new long sleeve rash vest because they don't want them to get exposure to the sun and die of a malignant melanoma, but then she doesn't get any vitamin D either. And then couple that with my daughter is also celiac, so she doesn't retain vitamin D or iron anyway. So just bear in mind that most people need a vitamin D supplementation, and most kids' conditions are now getting linked to vitamin D levels. Do you have any guidelines on maximum training frequency for peds? If you go with the adage, and a 12-year-old can do 12 hours, a 13-year-old can do 13 hours, it's a load of rubbish. It's about what they've trained to do. So if you think about the work from Niru Gianthi and Tim Gabbett, then basically they'll look at kids who've got different thresholds. If you've been training since you were 6 as a gymnast and you're now 13, your body's pretty well adapted to it. And you may have to change that if you go on holiday or you get injured or you basically maybe have a vitamin D issue or something like that, or you go through a growth spurt. But basically what you've trained to do is what you're ready to do. And therefore you've got to basically say that at the beginning of a school term, when the child is probably had the summer off, and then they go to pre-season training and about 20 different sports in week 1 of September, is it any surprise that the research says 3 weeks into that term is the highest frequency of apophysitis and stress fractures for the whole calendar year? So it's about what you've prepared for. What have you done in the last 4 weeks that's prepared you for your decision making this week? Advice for parents: become a high performance director and learn about nutrition. I was on a fast track. God blimey, windsurfing, I didn't have a clue. And so I suddenly had to learn about a zillion different things. And joking apart, I have a handout that's really useful for parents. You're very welcome to ask for it. But yeah, it's about educating not just the parents, but the coaches. So yeah, there's a lot to go at with that comment, Helen, but I'm happy to reach out and share with you some things. Best resources for red flags, that PMM online, there's a whole module on it and it's free. How do you approach mental health issues which relate to the child's injury when parents are present during assessment? It depends. If I think, like in this kiddie that I've got at the moment, whose mother decided to tell the kid she was fat, and the kid then was told that she couldn't have any carbohydrates and she was down to 1 meal a day, and the kid now has anorexia. That was straight to the GP. This is a safeguarding issue. I didn't mess about. That's a big end of the spectrum. But it depends on whether we think the parental drivers are there, whereby maybe they're being very pushy, maybe they're putting a lot of pressure on the kid. Then quite often I will sort of see whether maybe the kid wants to come in on their own and chat to me. And as long as we've got parental consent, that can happen. But most commonly, I'm pretty honest. You know, I'll explore with the kid. You know, I trying to get them to speak and allow them to have an opinion. And quite often I'll shut the parents down a little bit and say, it's really important that I hear what language the child uses, because that's the words I want to then use. So just let them have a go. And if you think they've missed anything out, then let you fill in, but let me just have a chance to talk to them first. But it's really, really sensitive, Victoria. I totally get that. Within my online course, there is a whole module on dealing with parental input and the psychology of how to talk to a child and how to get that information out of them. Communication with the kid is a big topic. Is there anything like bilateral shin splints in post-adolescent females? There is bilateral shin splints. So what you need to be aware of is these relative energy deficiency kids not getting enough sort of vitamin D, not getting enough fuel, and doing too much too soon. If it's in the absolute anterior tibia, then they have a potential, because it's like the bowing side of the bone, for not healing. So as long as it's postural medial pain, we treat it like medial tibial stress syndrome. And if it's on the anterior tibia, it's a big get them imaged as quickly as possible, because those can sometimes not heal. But I'd always want to be on the why, because this kid will be going at life at a 10 out of 10. All my bone stress injury kids look at me as if to go, surely there's only one intensity that one can go at. You told me to do my best, and my best means 10 out of 10. And if I don't try hard, I'll get dropped. Dead simple in a kid's world. What messages do we give these kids? Wow, there's a lot of questions. Okay, breathe, fluid.
Yeah, you have some with there.
How reassured are you from plain film x-rays? GPs typically unable to refer for MR. Depends how I write the letter, Nick. If I write a letter that basically says, this child has a potential pathology that I don't understand, and you basically talking about sort of bone stress injuries, stress fractures, then they do have permission to onward refer at that point. So I'm afraid I tell the parents that I'm going to be writing a letter with some seriously scary words in it. And then I load the letter up very heavily until I'm getting what I want. Now, you won't get any joy. There's no point doing an X-ray, for example, for a bone stress injury, particularly in the lumbar spine. It just doesn't show. So in essence, we know that they need scanning. So in my NHS world, what you're basically looking at is that I will basically treat as a stress fracture until proven otherwise. If I can't get an MR scan, and I've got a kid at the moment, we are just managing the symptoms. And if he doesn't get better, I'll go and jump up and down and tell the GP that we haven't got any choice now. But as long as basically they're responding to what I think is a bone stress injury, I treat it as a bone stress injury until I basically come unstuck, like I did for that little boy with bilateral severs, where he didn't respond to treatment. I didn't have a Scooby-Doo what was going on. And I, at which point, had to start exploring, was this some kind of bone necrosis? Was this some kind of infection? And at which point the GPs will start to get a fast track down there. But it is tricky, Nick, I totally get that. Sartorius avulsion criteria for surgical management, 20 mils gap or more. So generally is the cutoff. Anonymous, thank you, was thinking of a child who just started frame running. So no difference, basically. They could get severs and they could get a bone stress injury because they've increased their load. So just like a child who's not got CP, sudden spike in activity is your biggest cause of a bone stress injury or a sever. So absolutely could. And we're seeing this more and more in the CP population. Active 12-year-old, no growth spurt yet, tender inferior to patella, more likely to be Sinding-Larsen's or apophysis rather than PFP. If it's at the inferior pole of the patella, it is Sinding-Larsen's. Or don't forget your fat pads. Fat pads are really prevalent, especially in both these Sinding-Larsen's and the fat pads tend to be the hypermobiles, the hyperextension, stand a bit like a duck, and basically everything's digging into that knee, as opposed to the patellofemoral pains don't like flexion. So there's your differentiation. Your patellofemoral pains don't like flexion. Your Sinding-Larsen's quite often don't like hyperextension, and your fat pads definitely don't. Oh, we're nearly there. With an increased number of 12 to 16-year-olds, OA. What does that mean? Starting gym training. Is there an increased risk of tendon, bone overload?
I think.
What do we think?
Is it years of age?
Could be. Good one. Years of age. YOA. There's a good one for me. I like that. We'll make it up. And so, yes, two things. Don't forget that you can get in the gym bunny male population, that age group, they can get what we call clavicular osteolysis. So the end of the clavicle decides it's really not coping terribly well with pec dex. And they can get like a real erosion of that bone end at the distal clavicle. And then, yes, massively, we're going to see some of these deadlifting kiddies. I had a kid who did a bilateral deadlift with a real load, popped both his hamstrings off the other week. Not good for his cricket season. Thinks he's going to bowl faster, but he ain't going to bowl because he hasn't got any hamstrings attached anymore for the next 6 months. So yeah, bad time to do it. Believe it or not, I've seen my first OSD today. So very timely for me attending tonight. 13-year-old boy, grown a lot, physically mature through puberty, football arrested over Christmas, but mild pain on return to training. Yeah, basically build him back in, get him stronger, isometric quads, then start to go eccentric, start to get into your wall squats, and don't forget soleus. Soleus and knee pain is huge. Huge. Soleus has to work a whole lot harder than posterior glute med, so go distal, not proximal, before you start strengthening. They've got to be able to push up through soleus before they push through the glutes. Okay? The knee's just piggy in the middle. It's just like a little hinge that goes help and not coping, Osgood Schlatters, always make sure you check out those tight hammies, and that means weak glutes. So you've got to go proximal and distal in these Osgoods. Don't just hone in on the quads. Your passion to fight for your patients is commendable, and your passion shows. This has been a pleasure. I think that's a perfect way for me to stop, breathe, and say thank you.
I couldn't agree more, Ange. I tried to stop. I just couldn't get there. The passion was flowing in full flow there. On that very positive end, really, excitingly, we have announced the winner of your free place on the course.